Hello everyone, it's Monz Ahmed here. I'm a gastroenterologist in Birmingham, UK. In this podcast, we will be talking about endoscopic ultrasound guided biliary drainage. Now, we all know that ERCP is widely used in current practice to drain the biliary system. And in cases of failed ERCP, percutaneous transhepatic biliary drainage, that is PTC, or even surgical interventions have conventionally been used. However, nearly 20 years ago, in 2001, Giovannini and colleagues first described the use of endoscopic ultrasound-guided biliary drainage, and since then, this technique has gathered immense momentum. Today, I am joined in the Friends of Endoscopy virtual studio by Bharat Paranandi and Aaron Waihang on to talk about EUS-guided biliary drainage. Bharat is a gastroenterology consultant at Leeds Teaching Hospital. He has an interest in pancreaticobiliary endoscopy, and Aaron is one of the SPRs on the gastroenterology unit at Leeds. Thanks to both of you for joining us today. So, gentlemen, can we start by talking a little bit about the background of EUS-BD? What biliary structures can we access using this technique? How do we access these structures? And when is it appropriate to use a particular technique?
So EUS-guided biliary drainage has been around for about 10 years in evolution, and really we've been practicing it more commonly and routinely as part of our ERCP practice in big tertiary and quaternary centres in the UK over the past 3 to 5 years. So in Leeds, we have a considerable amount of experience in this. There are a number of ways in which the biliary tree can be accessed endoscopically, as you know. With EUS guidance, that can happen either intrahepatically or extrahepatically. From the extrahepatic point of view, the bile duct can be accessed usually via the duodenum, which is called a choledochoduodenostomy. The intrahepatic bile ducts can be accessed from the stomach, which is called a hepaticogastrostomy, and that is usually when we access just the left side of the intrahepatic ducts. The right side of the intrahepatic ducts cannot be accessed via EUS guidance. And finally, the gallbladder can also be accessed through the stomach usually, but also through the duodenum, and that is called a cholecystogastrostomy. The decision about which access route we take depends on usually the pathology and any other confounding elements. So if a patient has a distal biliary obstruction, and usually that would be in the context of a failed ERCP for example, duodenal obstruction combined with distal biliary obstruction, then we would tend to perform an extrahepatic puncture of the bile duct, which is called a choledochoduodenostomy. If a patient has, for instance, hilar obstruction of the biliary tree, and therefore we can't access the extrahepatic route to provide biliary drainage, we could then think of accessing the intrahepatic ducts on the left side, thereby performing a hepaticogastrostomy. And that would be in the context of a patient who would not be suitable for ERCP because of duodenal obstruction or previous surgery that causes anatomical variation, making ERCP impossible. Cholecystogastrostomy is usually reserved for patients who have often malignant or certainly surgically inoperable cholecystitis and gallbladder empyema as a result of cystic duct obstruction, either from benign causes, for example, stones in the cystic duct, or more commonly from malignant infiltration of the cystic duct from cancers of the biliary tree.
Why have these techniques become more mainstream in the past 3 or 4 years, do you think?
Well, I think over the last few years we've understood the need to be able to provide patients with timely and single-step procedures to resolve their episodes of biliary obstruction. Some of the problems that we've had with PTC over the years is that the outcomes from PTC can vary very much depending on which centre it's performed in, and it tends to be performed in a much sicker group of patients. So we know from various studies that have been performed, including quite a significant study that was performed in England looking at HES data from at least 10 years, I think, of PTC statistics, that the outcomes were very, very heterogeneous across England, and weren't particularly favourable. And so we've realised that there is a need to offer patients like this something else. With a PTC, it's often not a single step procedure, it's often dual step or even 3 steps, and occasionally patients can be left with external permanent biliary drains, which is difficult in terms of quality of life and can be uncomfortable for the patient. So the advantages of EUS-guided biliary drainage is that it's a single step procedure. It can often be done under sedation. It can often be done extremely quickly. So whereas a PTC might take in the realm of an hour or more, EUS-guided biliary drainage from start to finish can be done in about 10 minutes.
Is that because of the availability of these new hot lumen apposing metal stents, which allow you to do everything in one fluid step?
Absolutely. So the development of these new cauterized stents, which allows single-step deployment and puncture of the bile duct through the duodenal wall, has absolutely revolutionised what we've been doing with EUS-guided therapy. And without those, I don't think that EUS-guided therapy would be as far ahead as it is now. And certainly that is primarily the reason why these procedures are so quick and have a favourable risk profile when compared to other things such as surgical intervention and percutaneous drainage. So from a patient perspective, a successful EUS-guided biliary drainage procedure is generally a single procedure, as I said, under sedation, sometimes under general anaesthetic, whereas there is a morbidity associated with percutaneous drainage in terms of post-procedural pain, reduced quality of life, potentially the need for an external bag, either temporarily or definitively, and certainly the need for multiple re-interventions to eventually internalise that drainage bag, which you would not have with EUS-guided biliary drainage. Of course, there are risks with EUS-guided biliary drainage which can't be underestimated, but we'll come on to that later in the talk.
Which patients should be considered for EUS-guided biliary drainage?
So historically, EUS-guided biliary drainage has been used primarily for patients with inoperable malignant disease. However, things have changed. It should be in the context of malignant disease, and that decision should be undertaken after careful discussion with a multidisciplinary team, either in the context of a cancer MDT or out of a cancer MDT. At Leeds, patients with malignant distal biliary obstruction who attend for an ERCP are also pre-consented for EUS-guided biliary drainage at the same session should ERCP be unsuccessful. And we are very careful not to let our ERCP technique slip and not to use EUS-guided biliary drainage as a crutch for bad ERCP technique. I think that's very important to state. Usually this is going to be in the context of patients, as I said, who have inoperable malignancy, who have an inaccessible papilla either due to duodenal stenosis or indwelling duodenal stents or ampullary infiltration or previous surgery. And those are the best examples of when EUS-guided biliary drainage is appropriate. Occasionally, it is used for patients who have very difficult and impossible biliary cannulation. We are starting to use it after extensive discussion with our pancreatic surgeons in patients who are potentially operable, because again, it's a very quick procedure, it's very safe, and it leads to a much quicker resolution of jaundice and cholangitis.
What about this combined technique whereby the bile duct is punctured under EUS guidance and a guide wire is advanced antegrade through the papilla to perform a transpapillary procedure?
And absolutely, and what you're referring to is called an EUS-guided rendezvous technique. We have a lot of experience in that, and our experience is that firstly it's a multi-step procedure. It tends to involve a general anaesthetic, that our outcomes are less favourable than that of EUS-guided choledochoduodenostomy, probably because of the reasons that I've mentioned. Because it is multi-step, patients seem to be more prone to getting complications such as cholangitis post-procedure. Maybe part of that is due to the fact that we're inserting a guide wire from the duodenum to the common bile duct, which is then remaining in situ for some time under tension, and there may be an element of shearing that's going on. It's difficult to say, but we certainly feel that our outcomes for EUS-guided direct stenting are much more favourable to rendezvous. And I suppose what I would say in addition to that is if it's, for example, the reason for the failed ERCP is duodenal stenosis, then that would be a moot point. You couldn't perform a rendezvous procedure. If the reason is because you just can't cannulate, then my argument to do a stenting procedure is that you've already probably then submitted a patient to 40 minutes, maybe an hour of potential attempts at cannulation. Sedation tolerance is going to be waning. In essence, what an EUS-guided biliary drainage procedure from the duodenum is just a high pre-cut fistulotomy. And so if you kind of look at it that way, and especially the fact that it can take as little as 5 minutes, I think it's pretty clear that it's probably going to be favourable above a rendezvous. We do very occasionally, in very highly selected patients, perform these procedures on patients with benign disease. So, an example of that would be a patient with chronic pancreatitis with significant variceal disease in the abdomen, benign biliary stricturing and duodenal stenosis, who presents with severe jaundice and maybe cholangitis, in whom an operation is never going to be possible. And that is also another example of the kind of patient that might be suitable for this, but again, it would be through extensive MDT discussion.
Should EUS biliary drainage be used instead of advanced ERCP techniques such as needle knife precut or needle knife fistulotomy?
So the short answer to that is no. I don't think that it should be replacing good and standard and conventional safe ERCP technique. In patients who have preserved ampullas and preserved major papillas, failed conventional biliary cannulation would usually lead to performing an ancillary technique such as a pre-cut papillotomy or a needle knife fistulotomy, which are very safe, especially if they're performed reasonably early on rather than waiting, an hour into the procedure to perform them. They're reasonably safe and they have a very good success rate. So rather than removing one scope and putting in another scope and starting with a different procedure, I do think it is certainly wise to try and go through your armamentarium of ERCP techniques before resorting to EUS-guided biliary drainage. But I suppose the other aspect of this is that all these decisions need to be made fairly swiftly. You have to consider the patient's sedation tolerance. You have to consider their need for biliary drainage. Will protracting this procedure and avoiding successful biliary drainage from occurring on the day cause them detriment? That's what you've got to ask yourself. And if the answer is yes, then reasonably quick decisions have to be made to progress from standard cannulation, ancillary techniques such as fistulotomy, and if that fails, then consider EUS-BD.
How about patients with malignant strictures? Will these techniques affect the subsequent resectability of the lesion?
So, as I mentioned before, we have got considerable experience now of doing these procedures in, especially choledochoduodenostomy, primarily in patients with potentially resectable disease. And a lot of this depends on the site of the stricture. A choledochoduodenostomy done to relieve obstruction from a distal malignant biliary stricture does not hamper the operative field for examples of Whipple's pancreaticoduodenectomy. In Leeds, the last time we have gone through our data, 6 of our patients with a CDD stent have gone on to have a resection, and our surgical colleagues have not encountered any particular technical difficulties as a result of leaving that stent in. Similar reports of resectability in patients who've had a CDD with either a lumen apposing metal stent or an old-fashioned self-expanding metal stent have been published in the literature. We don't tend to perform EUS-guided hepaticogastrostomy for patients with hilar strictures who are operable, and those patients would tend to go for PTC. And part of the reason for that is if they are operable, then trying to relieve that established fistula between the remnant liver and the stomach without requiring that patient to have a partial gastrectomy or something more extensive would be very, very difficult. Whereas to remove a CDD stent as part of a Whipple's procedure would be part of the standard technique because that part of the duodenum will always be removed. A previous gastric bypass procedure, we can not perform a choledochoduodenostomy as such, a standard choledochoduodenostomy, but we can consider something called an EDGE procedure, which is an EUS-guided transgastric ERCP. So In that kind of patient, what we would do is use the EUS scope to put one of these larger lumen apposing metal stents between the remnant and excluded stomachs, which we identify under EUS guidance. We then use that stent to traverse into the excluded stomach with an ERCP scope and then perform a standard ERCP. So we've done 7 edge procedures. The majority have been for patients with biliary stone disease who have not been candidates for surgical resection. And most of these would have been patients who've already had their gallbladder removed and are either not fit or have declined surgical intervention. In those patients, a PTC is going to be less favourable because it's very difficult to get out big stones via a PTC, basically, and to prevent the patient from being left long-term with a biliary drainage bag. We've had one patient who had biliary stone disease due to causing acute pancreatitis, which has also caused a large walled-off necrotic collection next to the excluded stomach. So that patient had an ERCP from the excluded stomach and also an EUS-guided cysgastrostomy from the excluded stomach as well.
Are there any contraindications to EUS biliary drainage?
So there are relative contraindications. So patients who are unsuitable to have sedation or a general anaesthetic for an endoscopic procedure would not be able to have this because we would not even consider doing this under throat spray or without any sedation whatsoever. Generally, patients have to be very still. Although I've said that these can be as quick as 5 to 10 minutes, that things can sometimes go wrong, and if they do go wrong, then a patient may need to be sedated for longer. So that's certainly important to realise. Patients with altered gastrojejunal anatomy, for example, who are post-gastric surgery rather than gastric bypass procedures, maybe, for example, if they've had a Roux-en-Y anastomosis, or they've had a previous Whipple's pancreaticoduodenectomy, those kind of patients would not really be suitable for extrahepatic puncture, and we may have to think of other types of techniques, for example, balloon enteroscopy, assisted ERCP, or consider PTC in those patients. Patients who are precluded from intubation with an endoscope, for example, those with head and neck cancer with severely altered head and neck anatomy, those who are profoundly coagulopathic or thrombocytopenic, but those particular facets can be overcome by correcting those numbers prior to the procedure. The bile duct, most importantly, has to be sufficiently dilated to allow the procedure to take place. So generally, our rule of thumb is that the minimum size of bile duct that we will tackle is 12 millimetres. We have gone down to about 10 millimetres, but the risk does go up considerably in those patients that your bile duct stent will not open up and deploy in the correct space, and that you will have a stent that opens up in the duodenum rather than in the bile duct. And certainly, if you're starting this practice, I would not go for any bile ducts that are less than 14 millimetres to start off with.
You briefly touched on this earlier, but is there still a case for using PTC in some patients?
Yes, there certainly is. So those patients who have altered surgical anatomy that's prohibitive to any form of endoscopic biliary intervention, and also certainly patients who require drainage of the right-sided intrahepatic ducts, which we can't perform via EUS guidance. What I would also say is that I think this is a very specific question depending on which unit you are part of. If you're part of a unit that has very, very good outcomes from PTC, then I think that is one consideration to continue PTC in some of these patients. If you're from a unit that has very good outcomes with EUS-guided biliary drainage and can offer these procedures extremely quickly with good support from pancreatic and HPV surgeons, as well as specialist radiologists, and you have all the team back up behind you, then EUS-guided biliary drainage may offer a significant advantage.
Thank you, Bharat. Aaron, what are the risks of EUS biliary drainage?
So if you look at the data out there, there was a big meta-analysis a few years ago looking at 23 studies of EUS biliary drainages and around 1,200 patients in total, and they found the cumulative adverse event rate at 23%. And so the top few adverse events in these studies were bleeding at 4%, bile leak at 4%, neuroperitoneum at 3%, and so on. But then you have to bear in mind, as Bharat mentioned, EUS biliary drainage encompasses many different procedures, many different types of procedures and techniques. And this analysis included all techniques and all procedures. As we know, for example, patients who undergo EUS rendezvous, which is a multi-step procedure requiring multiple instruments and exchanges, there is a higher risk of something like bile-leak, for example, because the longer the procedure takes, the more likely it is for bile to leak around the space created by the initial puncture. Similarly, there are some adverse events such as Neuroperitoneum, which can be detected during the procedure. For example, in the process of creating a cholangitis, a bit of air leaks into the peritoneum, and that can be bridged with a stent with no real clinical consequence to patients. But of course, it has to be recognized immediately. For example, in procedures such as EUS rendezvous or EUS integrated therapy, there is a risk of pancreatitis because you do instrument closer to the papilla. You don't get that risk with EUS cholangitis because you're not close to the papilla in any way.
The literature tells us that the risk of complication of EUS-BD is at least 15%. Can you tell us a bit more about complications?
So if you look at the data out there, it does quote a rate of 23%, but then each procedure is quite different and the risk profile is quite individualized to each type of EUS-BD.
What about the risk of pancreatitis?
So broadly similar to our ERCP complication rates, in particular post-ERCP pancreatitis of 3 to 5%. Specifically to EUS biliary drainage, we do quote the risk of bile leak, which is not the case in ERCP. And when we quote the rate of bile leaks to patients, we give a percentage of 1 to 2%.
So how would you know if a bile leak has occurred? Would the patient develop abdominal pain and you have excluded pancreatitis? How would you know?
It can be difficult to determine during the procedure, and usually after the procedure, patients may develop abdominal pain, peritonitis, any features of a systemic inflammatory response, for example, pyrexia, tachycardia, and so on. And it would be really important to get urgent cross-sectional imaging to assess the intra-abdomen to see if there's any evidence of peritonitis or any fluid collections, which could be biliomas and so on. We also consent patients with regards to mal-deployment of the stent. It's something that can sometimes be overcome during the procedure, for example, either replacing with another stent that is then confirmed to be in the right position, or for it to be bridged with, for example, a metal stent to secure the tract.
I mean, pneumoperitoneum is something when you're performing extra anatomical punctures is unavoidable. So we always report a small amount of neuroperitoneum is part of the procedure, and it's something that we would recognise. So I suppose the most important thing is to go by a patient's clinical symptoms and their early warning scores. If a patient has a little bit of pain post-procedure like this, even post an ERCP, that's to be expected. If they still have pain at 4 hours, then they should be kept in hospital overnight. At that point, I'd be very cautious about performing any imaging at all unless there was a severe acute crisis with the patient that warranted it. If pain was getting worse, early warning scores were going up, patients were needing incrementally large amounts of analgesia, which was out of keeping with just post-procedural pain, I think that should alert one to the need for further investigations, initially blood tests, maybe a scan. But I think that usually these kind of complications you would be aware of at the time of the procedure. At the time of the procedure, you have a very good understanding as to whether the stent is in the right place. You have a very good understanding as to whether there is significant pneumoperitoneum, afterwards, the chance of the stent then spontaneously falling out is pretty unlikely. So generally, we would know around the time of the procedure, but we have to be very careful because, we are very understanding of that, but especially people who have less experience in these procedures may not understand that, and it may lead to unnecessary interventions.
Are there any special considerations regarding the recovery of a patient following EUS-BD as compared to a patient who has undergone ERCP?
No, at Leeds, the patients are recovered in the same way in endoscopy with a specific protocol post-procedure. We've also had patients who have attended the unit for day case procedures and have been discharged successfully. Similarly, we've had patients who had been transferred from other hospitals to have the procedure done over here and then transferred back to the hospital on the same day. If neuroperitoneum had been noted during the procedure and the patient gets a bit of abdominal pain, if you scan the patient quite quickly after the procedure, you will still see it, but it may not need reintervention, and after some time that air just reabsorbs. So it's taking things in the context of the patient's.
So, do you use prophylactic antibiotics when you do EUS-BD?
Yes, at Leeds we do give a single dose of prophylactic antibiotics unless the patients have already been treated for cholangitis beforehand. If you look at the sort of different studies out there, this practice doesn't seem to be uniform. Whether it's not reported or whether it's not done, it's not clear. But certainly at Leeds we do. If we look at the rates of cholangitis in our patients who've undergone EUS choledochordodenostomy, the rate of cholangitis post-procedure is around the realms of 10%. But interestingly, it all seems to happen not immediately after the procedure, but around a week or so after the procedure. And whether that's a result of reflux of gastric contents into the biliary tree as a cause of cholangitis is possible, but it's not something that we've encountered straight away after the procedure. Most of these patients would respond to just conservative management of antibiotics, unless there's any evidence that the stent itself had occluded or migrated. They can often be treated conservatively. If, for example, they get treated but then they remain septic, the jaundice doesn't get better, it gets worse, then it would be reasonable to re-image them to make sure that the stent hasn't been displaced or blocked, for example. But looking at our data, the majority of them could be treated with antibiotics.
So our rate of cholangitis now has come down as we've done more procedures. So we've done, I think, between 70 and 80 procedures now. When we first started doing these procedures, especially with patients with gastric outlet obstruction, we noticed that the rates of reflux cholangitis were a bit higher. And one of the reasons we felt that was the case was firstly because the stents in the duodenum were flat valving against the contralateral wall of the duodenum post-procedure and probably causing an element of transient obstruction. And secondly, because the stomachs weren't being drained or the duodenums weren't being drained or bypassed at the same procedure, that was leading to more gastric contents and bile filling up in the duodenum. So what we're doing now as standard as part of these procedures is firstly, through the metal stents, we place a short double pigtail stent just to push away the contralateral side of the duodenal wall. And that's just something that we're doing, but we have certainly noticed that in combination with same session gastroduodenal drainage or bypass has significantly dropped our rates of cholangitis post-procedure.
So would that mean an additional surgical procedure, or would you tackle the bypass endoscopically?
There's two ways that we do this, both endoscopically under the same anaesthetic. We either perform a duodenal stent at the same procedure immediately after the EUS-guided biliary drainage, or we do something called an EUS-guided gastrojejunectomy. And that's another new novel technique that we've been performing in a very similar cohort of patients. As a single step procedure, and then the stomach and the duodenum are drained, there's less chance of the stent being blocked by gastric contents, and the flow of bile is preserved into the duodenum, and then there's no risk of obstruction from the duodenal wall. You know, for many reasons, including the fact that we just didn't have the experience that we have now, we were doing them in separate sessions. So we're bringing them on one day for the EUS-guided biliary drainage, which, to be fair, was taking a lot longer because we were, more naive about them, and then bringing them back on another day for the gastric drainage procedure. But you can do both procedures all together within about 20-25 minutes. If you're doing an EUS-guided gastrojejunectomy, we can do both procedures within about 40 minutes.
So Aaron, in an EUS rendezvous or EUS antegrade technique where there is transpapillary drainage, would you use rectal NSAIDs to reduce the risk of pancreatitis?
Yes, we would, because it involves instrumentation around the vicinity of the papilla. The rates of pancreatitis in EUS-BD was 0.5%. And this is particularly in patients who did undergo EUS rendezvous and EUS antegrade EUS-BD patients, especially if it involves instrumentation around the papilla.
So that the kind of situation we're talking about is someone who would come down for a planned ERCP for drainage of a distal biliary obstruction, but then has to have an EUS-guided biliary drainage for one of the reasons that we've said. If a patient's coming down for a planned EUS-guided biliary drainage because they've had a previous ERCP that's failed, or they have known gastric outlet obstruction, then that would be different. We would not provide a non-steroidal in that sense. In terms of fluids, I think we look at the risk profile of the patient. So certainly all of these patients will be jaundiced, and patients who are jaundiced have a higher risk of everything, including cholangitis, post-procedure, and pancreatitis. So we would use a very similar approach, as Aaron said, to ERCP, in that all these patients should, if they're inpatients, they should be coming down to the department with fluids in place, having had IV fluids during their nil-by-mouth period, and being well hydrated, and so that's the most important thing to us. And if the patient's had an ERCP that's been difficult, and we think that their risk of post-ERCP pancreatitis is going to be much higher, then we would institute a vigorous hydration protocol post-procedure.
What sort of centre should consider setting up a EUS-BD service?
That's a really good question. I think at the moment the opinion from myself and the other more advanced therapeutic endosonographers around the country is that these procedures should be done in primarily in tertiary and quaternary referral centres who have not just a combined expertise of endoscopy of all sorts, ERCP related activity, and also diagnostic and therapeutic EUS, but primarily have a considerable backup with pancreatico-biliary and hepatic surgeons, dedicated radiologists, and a full MDT team, including highly skilled nursing staff, because none of this can be done without them. In terms of the people who should be specifically performing these procedures themselves, you know, myself and my colleague Dr. Huggett, we train around the country and internationally in these procedures, and we mandate that the person should be completely skilled and independent in diagnostic endosonography. They should have done at least 30 cysgastrostomy drainages before even considering to do a biliary drainage, and they obviously need to be in a centre which offers this level of support.
Looking towards the future, do you foresee a time when all ERCPists should be able to do EUS as well?
So I think that really depends on who you ask. I think if you're asking me, I think no. I think it's very important for us to have a breadth of ERCP expertise across the region in hospitals of every level, secondary and tertiary centres. I don't think that there is currently going to be the need to provide EUS at all those centres. So I think that performing ERCP well in secondary care environments is exceptionally important and required. We couldn't handle the amount of procedures that there would be in all in tertiary centres, and nor should we. This is a service that I strongly believe should be offered in every region in a tertiary capacity, which every secondary hospital should have a referral stream into. I think that's something that is a reasonable aim, an achievable aim, and will become the norm over the next 10 years. In Yorkshire, that one thing we're trying to aim towards is a regional network of consultants who can offer a specific on-call service. There are very few patients that would need to be done over the weekends, but there are some, certainly those in ITU with severe cholangitis, and I think as a regional network, that's what we should be aiming towards.
So what do you think is the next step for EUS-BD?
Well, I think right now what we're trying to really concentrate on is training. Training in endosonography generally is something that is a very difficult road. It requires at least 1 or maybe even more years, often more years, of advanced subspecialty training post-CCT. And actually recruiting for this kind of specialty when in the current era that we're in is not as easy as one might think, which is a shame because it's exceptionally enjoyable and it's really fulfilling, and you're getting to do things that no one else can do. You have a niche interest. It's fantastic. But in terms of what are the procedures that we can do, I think it will be doing more extra anatomical drainages of various parts of the body. We have, certainly in Leeds, we have the most experience in the country of these procedures, and we're the first to do many of them. But yes, I think there's about 5 to 10 units across the country are offering it routinely and have a significant amount of experience.
We haven't talked about the costs involved, have we? This is certainly expensive business, isn't it, Aaron?
Well, I think if you maybe factor in, for example, EUS-BD being a single-step procedure as opposed to undergoing a PTC, which is multi-step, leading to a longer length of stay in hospital and so on, it may work out to be cheaper with EUS-BD. Can't say that we've done the exact costings, but one would expect the cost to even out or would perhaps even be in favor of EUS-BD.
So Aaron, what is it like to train in endoscopic ultrasound?
So to tell you from my own personal experience that there is no general consensus on how one gets into HPB training. And where I train, it seems to be that you have to be independent in gastroscopies and colonoscopies before you even touch a ERCP scope. If we want to look at training the next generation of PB endoscopists and endosonographers, I think we need to try to standardize a way of getting trainees in the middle of their training rather than to leave it too late.
There is no carryover in technique between colonoscopy and ERCP, is there? So it doesn't make sense to demand competency in colonoscopy before starting ERCP.
So exactly, and that's why I think that this has to be standardized at a national level.
Okay, thank you. We're now coming to the end of our time. So Bharat and Aaron, thank you very much for taking part in this podcast and giving us some excellent insights into the fascinating world of endoscopic ultrasound. The next podcast will be a special Christmas edition. It will feature a quiz hosted by Bjorn. Look out for the publication date on Friends of Endoscopy. See you then. Bye for now.